Thank you for joining us for today's session. I'm your host, Debbie Mathias with the Build Initiative. We'd like to begin with a land acknowledgement from Giovanna Archuleta, Assistant Secretary for the New Mexico Early Childhood Education and Care Department.
I would like to open up this meeting acknowledging our Mother Earth and the land she nurtures us with, the land where our children grow, and the land that provides the food to feed them. When we talk about these resources, we must also acknowledge the lands of our tribal people and the deep spiritual and long-standing relationship of all tribal nations. Today I come from you from Nambe, the land of my ancestors who cared for it and fought for it so that I may one day live and raise my own children on it. A relationship that predates colonial contact by thousands of years. Our ancestors still speak to us and guide us through our songs, ceremonies, and writings. Through removal, trail of tears, long walks, assimilation, and the idea that by removing children would kill a culture. Our ancestors did not give up. Our tribal people are some of the most resilient people in our country, continuing to raise children to be resilient, who are nurtured through language and culture, the language and culture that cannot be removed. We must also acknowledge all other spirits who were forcefully displaced from their homelands and trafficked for labor and production on sacred native land. All of us collectively continue to experience the adversity that caused our ancestors and spirits who continue to hurt from actions done to them. Take a moment to pray these people find the healing and peace to raise their children in a world that has so many opportunities, but most importantly, create coexistence free of violence. Tribal people are praying people. This is where we are all tied. Our grandmothers and mothers continue to pray over us. And as tribal people pray, they pray for people in the north, in the east, in the south, and the west. They pray for infants, children, adults, and elders, and our non-human relations, each with knowledge to share with us. As this conference begins, I hope that each of you are balanced in all directions and take a moment to appreciate what Mother Earth has given to us and how she continues to nurture us in many ways. I invite and encourage you to learn who are the original stewards of the land you live and work on and support those nations and children of those lands. Thank you.
The Build team is excited to present this 20 webinars in 20 days for QRIS 2020 as we explore ideas, possibility, and learn together about how we might recreate better, more equitable systems with children, families, and early childhood professionals at the center of our efforts. We're grateful to the many individuals who took time to prepare sessions, generate content, and ideas to share. We believe the sessions will inspire you to build on these ideas, continue conversations, and innovate back in your own communities and states. Gosh, we've learned a great deal as we prepared for the virtual events. One of our lessons is that a virtual event draws a much broader audience than an in-person conference. The Build QRIS conference was designed for early childhood systems leaders at the national, state, territory, tribal, nation, and community levels. Well, as registration rolled in for the virtual event, we discovered many direct service providers from teachers to center directors and home-based providers signing up for the sessions. We welcome you to our learning community and look forward to hearing your perspective. We encourage you to share comments, ideas, and questions in the chat box. As you know, we had to pivot from our in-person conference to a virtual one. We'd like to say a sincere thank you to our sponsors who made that switch possible. Their support's essential to this event. Well, we've all become familiar with the Zoom platform over the past few months as we've used it to connect with friends, family, community, and colleagues. We want to point out a few features that may be new to you. First, when the PowerPoint isn't showing, you can choose your view in the upper right-hand corner. Click on a speaker to view to see the active speaker, or click on gallery view to see everyone with their cameras on. Next, we encourage you to provide feedback throughout the session by clicking the participant tab along the bottom of the screen to open the participant list, and then clicking on the icons along the bottom to respond to questions or give us a thumbs up. Presenters may also use this feature to do some quick polling, so be ready. Make sure to chat with us. We encourage you to be active participants in this session, so please share your experiences. There are some polls in this session, so a box will pop up and we encourage you to respond. This helps us generate more conversation, enhances our learning together. There'll also be an evaluation poll at the end. Well, now I'd like to turn it over to Debbie Sosin to introduce the speakers and launch this session. Thank you, Debbie.
Thank you, Debbie, and thank you everyone for joining us. And also thank you for that very beautiful prayer to begin us today as we begin to think about infant and early childhood mental health consultation. Dr. Kathy Ayoub and myself are delighted to be here, and I'd like to share a little bit about Dr. Ayoub, who has been a mentor, a colleague, and a friend for many, many years. And Kathy, if I can become a bit more personal, is one of the co-founders of Family Connections, one of the early childhood mental health consultation models developed, and also is a researcher, a clinician, a PI at the National Center for Parent, Family, and Community Engagement through Head Start and the Brazelton Touchpoints Center, and many, many other things, and I'm sure she can share a bit more about herself. I'm the director of Family Connections. I'm also a clinical social worker and have been working with children, families, and systems for the last 45 years in schools, hospitals, early care settings, and the community. These are new times for us, and we are all learning, as Debbie Matthias so graciously spoke about, how to change the way we do things and continue to be open and learn and partner with the families and other professionals that we are working with. So on to our next slide. I'd like to again welcome you today and to reiterate what Debbie Matthias had said. We're hoping that you will be actively involved and will share thoughts, comments, ideas, questions in the chat room, and we will be monitoring that. I know that so much has changed in the last 4 to 5 months. Our lives have changed dramatically through COVID and the pandemic, through the increasingly growing movement for equity and social justice in our country that many people are fighting for, and Zoom being the new normal for conferences. So lots to learn and lots to move forward with. Today, just to give you a quick overview of our session, we'll be talking some about the history of early childhood mental health consultation and share some definitions. Kathy will talk about one of the early mental health convenings that took place in Washington, D.C., and the impact of early childhood mental health consultation. And then I will speak more directly to a specific program model, Family Connections. So we would like to go over our learning goals with you. And very briefly, we hope that you leave today with a deeper understanding of infant and early childhood mental health consultation. And very shortly, we're going to do a poll so we can learn a little bit more about you and have some sense of what your understanding is at this point. We'll be talking about some of the key components of infant and early childhood mental health consultation and sharing with you some strategies and also along the way sharing with you some stories and experiences that both Kathy and I have had doing mental health consultation work. So again, I imagine we're a large and diverse group of participants. I'm hoping that we can learn from each other and that you will be involved and active. And in that spirit, let's do a quick poll to find out at our next slide a little bit more about who is with us. So there'll be 3 questions that will pop up, and if you'll take a moment to answer each one, and then we'll have a chance to know a little bit more about who is out there with us in Zoom land today. And I know, as Debbie had said, that when the BUILD conferences were in person, there tended to be one primary group of participants, and one of the positives about Zoom and the openness of time that many people have is that educators and other folks are joining today that might not ordinarily have been part of this group. So I see we're having some people writing in terms of the other. We do have someone who's a child care health consultant nurse, wonderful. We have a consultant for the Iowa Child Care Resource and Referral Board. Oh, someone tried the submit button and it wouldn't work. All right, let's see what we can do about that. We've got early childhood research and eval. That's right up Kathy's alley. We have a funder, thank you. We appreciate having the funders and need your thoughts, ideas, and input. A family engagement coordinator, some state level professionals, a number of training and technical assistant providers, preschool teacher's aide, thank you. I know some of the programs we work with here in Massachusetts, where Kathy and I are both based, have started back, the Head Starts, last week and the week before. So we're learning about how to social distance with infants and toddlers, how to support social and emotional growth and development when one is wearing a mask, and how we comfort little ones when they are upset and we are needing to keep our social distances as well. Let's see, we've got, maybe we'll give it another moment or two. It looks like our training and technical assistance providers are the largest group right now, and state level professionals. A number of specialists for classroom practices and coaches. And I know that there are many aspects of early childhood mental health consultation and the work of coaches that do overlap. Okay, so it looks like you're seeing the results now. So we know we've got just one federal level professional with us and a number of state level directors of some programs. Again, a number of training and technical assistance providers, 5 mental health consultants, I hope you'll join in, and 17 others who have shared with us. And in terms, so we have a diverse group. We've got people who've been in the field of early care for 2 years or less. And we have 42 people who've been with us in this field for over 42 years. So between us on the phone, we probably have many hundred hours of collective knowledge and wisdom that I hope people are going to be willing to share with us today as well. And how many of you have worked? So a little short of half, 44% of you have had the opportunity to work with a mental health consultant or are working with a mental health consultant or may be a mental health consultant. And 56% of you, 37, have not. So it'll be exciting to talk together for the next hour and 5 minutes and learn together. So at this point, now that we know a little bit about each other, I'd like to turn the presentation over to Kathy and begin our more formal conversation.
Thank you, Debbie. This poll was so interesting. Welcome to all of you. It is so rewarding to see all of you who really have different perspectives and different facets, and it sounds like different times in the field really thinking about infant and early childhood mental health consultation. The first thing I really want to focus on is that this is rapidly becoming a very important and ever-growing field that is increasingly important to the programs, the communities, the providers, the children, and the families that we serve. And it really is also a very important part of mental health practice. So thank you all, and hopefully we can ask you to be active, put your comments and your questions in chat as we move along, because we do want to make sure that we are at least able to address some of the questions. There are a lot of you on this webinar, so we're going to try to at least touch on a number of main themes. So thank you. And with that, I'm going to kind of jump into a bit of a historical overview before Debbie really talks to us about the real core and the meat of doing mental health consultation. I wanted to admit that my perspective is probably biased, so I'm going to give you the perspective of one person. I did poll a number of my colleagues to pull this history together. So some of you may really want to add to it as I go along. And again, please put that in chat as well. I remember through graduate school, I'm both a psych mental health nurse practitioner with a focus on early childhood and a clinical psychologist. You know, my mother just told me I liked going to school, so there you have it. But even thinking about both of those professions, and I've had the wonderful opportunity to learn from FIRST and to work with many, many of my social work colleagues, as well as my child psychiatry colleagues and counseling colleagues. And I think those are the group of, that larger group, the group of mental health professionals that have been thinking about mental health consultation. The earliest references that I've been able to find to mental health consultation in general come from the community mental health movement back in the late 1950s and 1960s. And a child psychiatrist by the name of Gerald Kaplan wrote about the importance of doing consultation around mental health issues and services, particularly when, as a nation, we were building community mental health centers. And some of you may have the good luck of having some of those organizations still be embedded in your communities. A number of them have morphed into joining other organizations or even primary care. But that's really where it started. And I think, at least I remember from my nurse practitioner training, I received a very kind of what we would call a medical model, a healthcare model of mental health consultation, and actually did mental health consultation in hospitals and outpatient pediatric and family practice programs for about 10 years before I ventured into what has been the incredible field of early childhood, infant and early childhood mental health consultation. But I think that the constructs, and Debbie's going to talk about these more later, are really the same. That we really go in with a primary view to support the capacity of the people who are providing day-to-day service for young children and families. And that's been the core throughout this process. I noticed in chat that there are several of you have said, I've been in the field 25 years, I've been in the field 30 years. I know Debbie and I have both been there for a long time too. And so there have been a small but mighty number of us who have been doing this work, particularly with young children and families, for some time. But we've been a fairly small group of folks. About 15 years ago, there was an additional kind of push to really think about how important it was to work with young children. 20 years ago, 15 years ago, some of this really coincided with all of the work on brain science and the discovery that it really made a difference how we interacted with the young children, and that some of the opportunities around their mental health and wellness was critically important to their lifelong trajectories around development and learning, and really impacted on their abilities to become caring, contributing citizens in this now global world. So that particular set of understandings around early childhood brain development really gave us the impetus as mental health professionals to work with young children and families, and then also to think about this consultation stance. And again, Debbie will tell you more about how this is different from treatment, which I know many of you embedded in the field really know. So one of the real issues with mental health consultation is how vital is it? What do we know about impacts? And how is it that mental health consultation can become embedded in the programs that are offered to young children and families, both in health, and we're really going to focus on early childhood settings. And I include in those both center-based care, maybe 2-gen programs like Head Start and Early Head Start, child care, home visiting. And these are key ways in which as professionals, we touch the lives of young children and families. So how is it that we can embed mental health consultation? But I want to tell you a story because I'm still amazed. And so if you'll put up with my history giving, back in 2014, I was actually at a conference that the administration, that SAMHSA, the Substance Abuse and Mental Health Services Administration, was putting on for some of their grantees. And I was sitting in a meeting with my colleagues from Georgetown who were very involved in thinking about mental health consultation. And we kind of, the end of a presentation, we kind of turned to each other and we said, you know, we really need to define mental health consultation for the field for young children, infants, toddlers, and preschoolers. And I'm not sure we've done that. So we actually cornered one of our very favorite federal partners. I'll put her name out there, and Jen Oppenheim, and said, you know what? We really need to get people together, both experts, and then we really need to talk to the federal folks who have some authority across particularly health and human services, but beyond. And this actually led to a convening that SAMHSA really hosted for a day and a half, what we call the expert convening on infant and early childhood mental health consultation. And for any of you who think that infant and early childhood mental health consultation is a mouthful and you wish we'd called it something else, you can blame us, because we didn't want to leave anyone out, and wanted to make sure that we named all those youngest of children. But this was a really amazing convening. There were a small, at that time, group of experts. Some of you actually may have been there, and please speak up. And we spent the first day really hammering out what was one of the first national consolidated definitions of infant and early childhood mental health consultation. And the second day, we had the tremendous experience of meeting with the senior federal leadership of organizations like the Office for Head Start, the Office for Childhood, the maternal, infant, and early childhood home visiting programs, those who also represented our Native American nations in terms of both health and early childhood. There were several people there from prominent foundations that had been invited. And it was amazing. They all came and they stayed to hear about mental health consultation. And it was here that we really began to consolidate a definition of mental health consultation, and I think Debbie's going to tell you more about and show you a little bit more about that definition in a little bit. From that particular meeting, one of the key things that happened was that the people who had the leadership to be able to think about the programs for which they were responsible in our federal government really thought about how can we help embed mental health consultation for these very youngest of children and families and the professionals that serve them into the work that they do. And one of the things that we talked about in that meeting was, first of all, based on the Office for Head Start performance standards, mental health consultation is already embedded as a required activity of Head Start and Early Head Start programs, but it wasn't very well defined. So we understood that mental health consultants were doing everything from going into a program once a year and observing classrooms and providing teachers with feedback to being involved in what we called a more embedded model of mental health consultation, in which there was a mental health consultant on site who really was integrated as part of the staff, either weekly or every other week, or even monthly at the very least. And this was someone who was doing what we call embedded mental health consultation, really there with more frequency, longevity, and really integrated into staff activities. There was one other key thing I wanted to mention about the history, and then I want to say a little bit about impact, and I'll turn this over to Debbie to talk about the real meat of things. But just to say that there were 4 key components of the definition. One, that mental health consultation was preventive. 2, that it could be multi-level, and that the mental health needs of leadership and community providers, children and families could be addressed, that it was relationship-based, and that it was always focused on building the capacity of the early childhood staff and program. And these were some other ways that made it very different from mental health treatment. That said, that's probably enough history, except to mention that the model that Debbie's going to talk to you about around mental health consultations, called Family Connections, is part of that history. Back in 2004, Boston Children's Hospital was awarded an innovation grant from the Office to Head Start to develop a model of comprehensive mental health consultation for infants and early childhood that would be compatible and be able to be used specifically at that time in Head Start and Early Head Start programs. The model is certainly being extended beyond those programs, but is still certainly a critical piece of work that's available to those programs as well. So enough about history. I'm sure you could each add your own. Now that I said I'm going to move on, I'm going to say one more thing. One of the things that's happened over the last 10 years or so is that states have taken an active role. And my guess is that there are a number of you here, maybe a quarter of you on the phone, who have really been working diligently within your state systems and have really moved to acquire funding through your state for mental health consultation and in early childhood programs. And I want to acknowledge that there are federal programs and there are state programs and then there are community programs. And one of my hopes for the vision in the future is that we can come together in even a stronger way to share with each other what we've learned, because there's learning across all of this programming. I've been emphasizing the way that things have come together at a national level, but the state work has been incredibly important to the field, and I want to honor that as well. The final thing I want to mention is that I think it's 6 years ago, SAMHSA in its wisdom decided to actually fund a center the Center of Excellence on Mental Health Consultation. It is in its second iteration. That primary grant is now held by my colleagues at Georgetown, and they actually do wonderful work nationally and connect strongly with states and tribal communities to provide resources, including there are a set of very nice training modules on mental health consultation, to which we have contributed through our National Center on Parent, Family, Community Engagement. The National Center, the Office of Head Start Health and Wellness has contributed, as has the Center of Excellence in Mental Health Consultation, of which I imagine some of you have been a part. So please speak up. Okay, I'm going to go on to the next slide and say something about, so if this is the history, what do we really know about the evidence base for infant and early childhood mental health consultation? What's really interesting is that there are impacts of mental health consultation in both systems and leadership and capacity building, around the act of consultation itself, skill building and workforce development for staff who are working in early care programs. Then we also have found that there are family level impacts. And I'll talk a little bit about each of these. And then we also have some evidence of child impacts, both working with children as groups, improving individual social emotional assessment, providing therapeutic support and intervention, and actually changing in some ways the relationships between teachers and children in positive ways, and also building social emotional skills and strengths in children. Through the convening back in 2014, here are some of the key examples of program-focused outcomes around which there is research or evaluation. We know, and many of you know my colleague Walter Gilliam, who probably is the best known for looking at issues of expulsion, and he was the first to do studies that really documented the relationship between decreased levels of expulsion and the presence of a mental health consultant in early care. We also know that, again, at the leadership level, the programmatic level, that the access to reflective supervision for staff provided by mental health consultation has also significantly increased the professional skill building and the morale of staff. So it not only has increased staff's ability to do their jobs, but it's also increased morale. For staff, we have evidence of reduced stress and burnout, of less attrition in some programs, and there are some other variables that also have to be in place when we usually see less attrition. Positive climate in a program, for example, is really important, as we've seen in some studies, to how mental health consultation really has the best or lesser impact. And then for the child specifically, we've seen fewer expulsions, improved school readiness. Just to tell you a little bit more, I want to specifically focus on teachers. What we know from the current literature is that with the presence of a mental health consultant there with some frequency, again, once a year or twice a year doesn't do it. All of this is really from studies where there is significant frequency or dosage of that mental health consultation service delivery. So we're looking at weekly or at least every other week presence of a mental health consultant. But in those situations, we see teachers with increased sensitivity to the needs and the mental health, both the mental health and physical needs of the children they serve, enhanced classroom management, improved classroom climate, increased capacity for managing children's difficult behavior, reduced job stress, and actually reduced sick time. So Again, from the expert convening, here's some of the things that we found at the provider level. Again, we found improved skills for staff around supporting social emotional behavior, development and behavior management, specifically improved the quality of teacher-child interactions and staff-to-staff interactions. And as I mentioned before, reduce stress and turnover, and an increased classroom quality overall. So we also could see changes in things like class scores or in some of the other classroom quality measurements. Here's a specific example, and I'm showing this just because it happens to come from our family engagement mental health consultation work, but I love this slide and just want to tell you what this is. We began to implement mental health consultation in Head Start and Early Head Start programs across Greater Boston, if you can imagine when, in the middle of 2003. And what we measured for 4 years before we started and for 4 years after was how much sick time staff were taking. And really what this shows you is not how much they were taking. This actually shows you how much sick time they had left, what the remaining hours were. So you can see across 4 years without mental health consultation, staff were taking all their sick time. They took advantage. And when we went in and interviewed staff to ask them about this, they said, you know, we just need mental health days. We just can't cope at times. Once we started providing, again, fairly intense mental health consultation in classrooms, this was the change that we found. And when we went back and asked staff, and we asked them yearly, they really said, you know, I don't have to take as many mental health days. I need some. And, you know, we had people who genuinely had other physical illnesses and they took sick time for other reasons. But we really found that the on-the-job stressors were reduced. So how does mental health consultation make an impact on children? We've mentioned a few things, but again, more specifically, fewer problem behaviors, so that not only do teachers have improved capacity to work with children who may present with challenging behaviors, we actually saw a reduction in children with problem behaviors in the classroom. And by the way, we know in this particular study that the children that were coming in, it wasn't that the children coming in had fewer problem behaviors to start with. It's that those behaviors were actually managed more effectively by teachers with a mental health consultant there. We saw reduced conflict between teachers and the children in their classrooms over time. Reduced expulsion always has to be there again and again because we know that's very important. Improved capacity for emotional exchange around difficult topics. And we did a specific study where we actually videotaped and counted the emotional exchanges at circle time and then otherwise. And there were significant differences when the mental health consultant was in classrooms engaged in particular interventions that really helped the children, along with working with the teachers around emotional exchange and accelerated positive social emotional development. This is an example, and I need to move quickly because I want Debbie to have time to do all of her great things. This is just an example of the reduction in teacher-child conflict with a mental health consultant there. And this actually shows you the impact of having more time on site with children and families and staff. The green line is an example over 2 years of the reduction in conflict between teachers and children. The teachers rated their conflict with each individual child in the fall and the spring. And you can see when there was a mental health consultant there for 3 hours a week, this is what we found. When the blue line, we had a mental health consultant there 2 full days a week, over 2 years, we found that there was even a stronger pattern over time. The reason this goes up and down, and this is interesting, is that if you'll note in the fall, the conflict between teachers and children was higher than in the spring, particularly with the blue and the red lines. And part of this because there were new children that arrived in many of these classrooms in the fall. And so the conflict actually went down as the teachers and the children got to know each other. And we saw the most reduction when we had mental health consultants in classrooms for more than 2 days a week. And we really saw this kind of continued reduction.
Kathy, may I share a story about this slide?
Absolutely, please.
It is always so exciting for me to hear the more academic outcomes of mental health consultation. I do have the honor and good fortune still to be working directly with a number of Head Start sites, and prior to COVID, twice a week or 3 times a week was able to go into sites and be in classrooms or sit with teachers and children and families. This is a slide that for me really captures much of what Kathy has been talking about, because I think of mental health consultation as capacity building, but also as a healing. It is truly in its best form trauma-informed care. And this is a picture to bring that back to us. We've done a fair amount of work with Family Connections and tribal nations throughout the country. We've been honored to be invited to work together with them. And this is a picture that was shared with permission, of course, from a tribal community where there had been a fair amount of domestic violence. And the impact of that violence was systemic. For the children, the partner who was abused, the partner who was abusing, for all of the many reasons we understand. And together, the children wanted to create a healing garden. So this was when they were planting their healing garden that anyone and everyone could go to when they needed a moment of peace and a place where they could calm, or as we might say in the early childhood mental health field, where they might practice their self-regulation. So I love this slide when we're thinking about impacts and looking at what mental health consultation can bring to communities and to programs. So thank you.
Thank you, Debbie. Let's move to the next slide. I love that slide, it's beautiful. I want to finish here very quickly. I want to say that one of the things about the Family Connections mental health consultation model is that I had the privilege of co-developing this model with my colleague, William Beardsley, who's a child psychiatrist. And his long-term interest has been in parental depression, particularly maternal depression, and its impact on parenting, and really how to really think about making sure that as mental health consultants, we're also thinking about families. And I know that oftentimes mental health consultants, just in my experience, sometimes it starts with a focus on the children in the classroom. We have an audience of those children there. But reaching out to families and working with families through family service professionals, through teachers, and doing some direct connection in service of building capacity is really important. So there are some impacts on parents that I don't want anyone to forget. Parents essentially miss fewer days of work is a wonderful study. Parents are better connected to services, particularly mental health services. And parents report improved well-being and engagement with program and community. So those are 3 of the pieces of material that come from mental health. So I'm going to go to the next slide and really end with this one and pass this on to Debbie. I think we've mentioned all of these issues around children, but just to reiterate, these are some of the key issues around which we have evidence in mental health consultation. Debbie, I also see that there is a question, and we can go to the next slide, and I'm handing this over, around the difference between mental health consultants and the work of mental health consultants and coaches. So in the context, I know you're going to talk about what is infant and early childhood mental health consultation, so I will leave you with that.
Wonderful, thank you. So I appreciate all that you shared with us, Kathy, and giving us the overview of early childhood mental health consultation, some of the history. What I'd like to do is bring all of you in at this moment before we get to that question, and have all of you thinking a little bit about early childhood mental health consultation and what that means to you, because we've seen some questions that people have asked about what is the difference between mental health consultation and coaching, what that pairs down to, and we will get back to that. But first, I'd like to ask you to take a look at this picture in the chat, and in the chat, please reflect for a moment and share with us what this picture evokes, what you think about, what this brings to mind when you see this picture. While people are typing, I'll share that I love these. It takes a community, it takes a village, kindness and diversity, joy and trust, certainly a joyful baby, coming together to raise the next generation. Absolutely. So many of us are involved in raising the next generation, and many hands to raise a child being honored, a child on a trampoline. So many of us are talking about the future and hopes and the village. I love children should be our highest priority. Absolutely. All services working together, diversity and reflection. So many wonderful things that people are thinking about when they look at this picture. We all need to hold our children, how true, and the generational influence and guidance. And this happens to be part of a two-story mural in a Head Start and Early Head Start program in the city of Boston that was painted by a community member. And this is the piece of the mural that is right in the middle that everyone sees when you walk into this building. And I always think when I walk in as a mental health consultant each week, it inspires me to do the work. And I can only imagine being a parent or a child or a teacher, because not only do we see this child being held up, space for children, the hope, the joy, the connections that children need, the diversity, the many shades of skin color that are holding up that child. But in addition to this, in the upper left-hand corner, we can just see a little bit, but it's a circle time with a teacher reading to children. And in one of the bottom corners is a mother nursing her baby. And so it really, for me in some ways, is the essence of early childhood, and part of why I do early childhood mental health consultation. We're going to be talking more specifically about family connections, which is a model that Kathy, Dr. Kathy Ayoub and Dr. Bill Beardsley developed. And I love to share the story of how this model developed, in that Dr. Beardsley's passion and expertise has been working as a child psychiatrist, working primarily with middle school and high school children. And his passion, as Kathy said, was working with families where a parent was struggling with depression, facing adversity. And it was so important to him that depression and mental illness, which is so often stigmatized and is kept quiet and is a family secret, be brought out into the open, and that families, particularly children, have the opportunity to continue to grow and thrive, even with, or perhaps because of, a parent that was struggling with depression. So he has created many years ago a program called Family Talks, a psychoeducational program that's now in many languages. It's available online at no fee, and it really helps families understand and think about depression, takes depression out of the darkness, which is the name of one of his books, and supports kids to go on and grow and thrive. And one of the regional directors for Head Start program read Dr. Beardsley's book, or saw him speak, I'm not sure, and went to him and said, how do we adapt this to families with young children? And Administration for Children and Families study had just come out in 2002 that showed close to 50% of early childhood mental health, early Head Start parents were screening for depression. And so I ask you, yes, and you can, the link to Family Talks, we'll see if we can get that for you and put it in the chat. If not, we can put it on the resource site. So when I share that research with people, and the research was done again, also similar research in 2007, that again, close to 50% of the parents, the mothers in early Head Start screen for depression, and ask people, do you think that's high? Do you think that's low? For you, what do you think about? Does that sound like a high number of parents in an early Head Start screening for depression, a low number? When I share this throughout the country, most people say that yes, they think that number is accurate, or that it's low, that depression is something that many families that attend Head Start struggle with for many, many reasons, systemic racism, poverty, the list might go on and on. So this Head Start person came to Bill and said, how do we adapt this program, Family Talks, for young children? And Bill went to Kathy, who had been always so passionately involved with mental health consultation in young children, and together they collaborated and developed Family Connections. So it is very much a prevention model, a strength-based model, and as Kathy said, built on relationships, and we'll talk further about that. And it's a system-wide consultation. In a very brief explanation, I will say that mental health consultation and coaching are similar in a number of ways, in that they both are preventive, that they both look to support the social and emotional well-being of children and families and staff. The mental health consultants clearly come with a mental health lens, with expertise and training in understanding mental health in a way that is unique to that particular profession. There's a wonderful crosswalk on the Center and Excellence for Early Childhood Mental Health Consultation that looks at mental health consultation and CEFL, or coaching, and how where the two overlap and where the two are different. So we'll see if we can get you that link, and if not, we can put it in the resources afterwards. So, we often think, as this Head Start regional director thought, how do we intervene early? How do we make differences in the lives of children so that there can be a change in their trajectory? We know that expulsion from early care programs has devastating impacts on children. People are probably familiar with the pipeline expression for children, you know, on their way to jail with expulsions. And so, you know, we know that it is so much easier to build strong children than repair broken adults. And this was a quote by Frederick Douglass, who in his day wrote Broken Men, but I think certainly he would probably not be opposed to me taking some liberties and generalizing that to all adults. So we're going to take a few moments to do a word cloud. I don't know if all of you are familiar with word clouds, but what we're going to do is put in the link a website that you can go to and type in 2 words, competencies that you think about when you think about what might be important for an infant and early childhood mental health consultant. So we've got the link in the chat. So if you can go to that link to Menticom and use the code and then begin to type in words for you that embody the competencies of early childhood mental health consultants. And Alyssa's going to share the screen, her screen, so we can see that word cloud begin to develop. Okay, here we go. And the way the word cloud works, if you have not used one before, words that are shared more frequently are bigger and more at the center of the word cloud. So we're seeing this develop in front of our eyes. So clearly compassion, loud and clear. Compassion is so critical for an early childhood mental health consultant. Patience, understanding, relationship building, empathy, love, reflective practice in those skills, reflection, relationship building. Again, the compassion and the empathy and the patience are so very prominent for people. Understanding, and when we think about mental health consultation, we think about understanding on multiple different levels. So again, understanding is taking, and compassion is, as this shifts and ebbs and flows. We've got reflection, collaborative. It's such a collaborative process, understanding. And as the words get smaller, as more people type in, I have to confess that my aged eyes are having a hard time reading some of the smaller. I don't know if the screen can be made any larger so we can see some of those. Understanding again. Okay, we're going to make that screen just a little bit larger if we can. I don't know if that's going to be possible. Love and faith. I see people are enjoying the word cloud. So copy down the website. This is a free service that you can use. It's wonderful for staff meetings. It's wonderful on Zoom for parent meetings with family members. Okay, so we've got diversity, we've got understanding, patience, reflection, collaborative, and that relationship building. So I think you have covered so many. Let's go on to the next slide, and hopefully we can put this word cloud, save it and put it also on the resource page so you'll have it. So I wanted to share with you the competencies, and this may also go back to the questions that people had asked about the differences between coaches and mental health consultants. And one of the pieces that did come out of the convening that Kathy spoke to in Washington, D.C., that a mental health consultant is a mental health professional with usually a master's degree in one of the mental, at least a master's degree in one of the mental health related fields, social work, counseling, psychology, and others. So at the core of the competencies we think about is really a deep knowledge and skill in mental health and looking at the mental health of adults, the providers, children, and families. And then as we kind of look at the concentric circles, there's some very specific consultation skills, and we'll talk some about the consultative stance as we move forward. So some skills and knowledge there. Obviously, infant and early childhood development, which is shared ideally with teachers, with coaches, with all of us in the field, and a knowledge of early childhood settings. You know, then we have cultural knowledge on the outside. And when I was looking at this particular slide and thinking how much, and one of our participants wrote early on in the chat that early childhood mental health consultation is certainly a step forward in the evolution of mental health. So is the term culture and cultural knowledge. And now, you know, we're thinking much more about cultural humility. We can never fully know another person's culture. We can learn, we can be open, we can be humble. So I like to think of that as a cultural humility and a cultural openness. And I'll share another very quick story about cultural knowledge and cultural humility. So I was doing a family connections training in a tribal nation in a pueblo in New Mexico, and it was lunch break, and I came to sit with two of the participants, two women and elder in the tribe, and a younger woman, both involved in their early care program. We had a lovely lunch and a very rich conversation. At the end of lunch, I needed to go back to the front of the room, and I was picking up my paper plate, and I asked if I could take theirs and throw theirs out, and they said yes. And there was a third plate there that had some what looked like to me some scraps on it, and I said, "Oh, may I take that plate?" And they said, "No, that's okay." And I said, "No, really, I can carry it." And they said, "No, that's fine. You can leave this one." And foolishly, I asked again. I said, "I can handle it." And they said, "No, really, it's fine." And I thought, Debbie, one of the major tenets of mental health consultation, listening. You're not listening. I got up, I threw them out, thought about it. At the end of the day, I wasn't able to catch up with them, and asked one of my hosts. And I think this was the first tribal training that I had participated in. And she was gracious enough to share with me about leaving a plate out honoring the provider, the creator, and that's what that was there for. And I, of course, felt horrible. I had stubbed my cultural toe. Later, I was able to go back to the women and say to them, I was so sorry, I wasn't listening, and apologized. And the older woman laughed and said to the younger woman, "I told you we just should have told her then." And I wish she did, but it was a real lesson for me in never assuming, and listening, and being open when it comes to culture. So if we move on to the next slide, I'm going to talk a little bit about what guides our work specifically in family connections. And so we know that so many of the families that we're working with have experienced adversity. That adversity including racism, poverty, health disparities, isolation, exposure to violence. And we also know that many professionals that are working in early childhood programs are at risk for experiencing related adversities. I know in many of the Head Start programs where I've worked, many of the providers have been Head Start parents and have, worked their way up to becoming a teacher in a program in a most, wonderful way. And also we know that depression is a common response to these kinds of adversities, that these adversities and their impacts, the resulting trauma, depression, really impacts the ability of the parents and the staff to relate effectively to others. When we're traumatized, when we're depressed, it really it shifts, as we know, our brain chemistry and how we're able to think, to relate, to be. And this impacts the children while at home in an early care program. So this effort to increase the capacity of each provider and providing support for mental health for both providers and families and children really increases the quality and the climate in early care settings. So that was kind of the beginning of Family Connections, and when this shift was made from Bill Beardsley's program for middle schoolers, and that was individually family-based, to this larger adaptation. So Family Connections really uses a public health model. It's a promotion, prevention, and intervention. We're really looking at that strong community and systems development level as our solid foundation, and then universal prevention for all children, for all families, because we know what is good for the mental health and social emotional well-being of a child who is truly struggling is also good for a child who's functioning well in the classroom. And then we look at that targeted prevention for those children or parents who might have more intense struggles or might be at risk. And for the uppermost is the clinical intervention and identification of the mental health needs of the children and or families that we might be working with. When we think about Family Connections, as we've mentioned, it really is a system-wide approach. It might be focusing more on the providers. It might be doing some more work with families. It could be working with the larger community and or the children in the classroom. You know, as a mental health consultant, sometimes somewhat different than a coach, we are really joining the classroom or the site's system. We're coming as a guest. We're invited in. Sometimes we're invited by a director and not a classroom teacher. So our work is to first build on that relationship and build trust. A very important piece of Family Connections, but any mental health consultation program, is to start with where the family is at, or where the client, where our site is at, and join where we are invited into and build in the process. So this is just, again, to share with you some of the work that was done with one of the tribal communities where the family and family engagement was such an important piece of the work that they did, and some of the work that we did together through Family Connections. So moving on, our approach in specific in the next slide, we begin with the Readiness Guide. We'll talk just a little bit about that as we move forward, and our Readiness Guide is available for folks in the resources on the Build website. Out of the Readiness Guide, we build a collaborative action plan. What is it that we're hoping to do together? And that may include professional development, and we have a number of manualized workshops that really focus on social and emotional well-being of children, families, and staff. We might do very specific mental health consultation in classrooms. It might be general, it might be specific to a child, to parents, providers in the community. And another component of our program is Tell Me a Story, which is a literacy-based social and emotional project that uses storytelling to help build the social and emotional well-being of children and staff. Quick story that I'll share with you before we get into this about Tell Me a Story. So we were reading a book, and often with Tell Me a Story, the mental health consultant begins the process by sharing, by modeling and reading the story, and then the teacher may read the story the second or third time. But in reading the story, this was a story about a child getting angry, very, very angry. This is Sophie gets angry, and we were reading it, and I asked the children about anger, and one child said, My father gets angry, really angry, and he punches the wall. And the teacher's response, only because I think she really didn't know how best to respond, was, well, we don't talk about that here. And I needed, in the most respectful manner possible, to be able to kind of honor the teacher and honor the child and continue the conversation, and then go back to the teacher afterwards and talk further. So a little bit about our readiness guide process. It's a shared and self-reflection exercise. It's a collaborative approach, and it really is perspective taking and diversity of the participants. It looks at a number of different categories from a site, from the program history, supervision and staffing, their goals and perspective on family engagement, goals and perspective on mental health, both for staff and for families. I'd like to kind of think about, and as we know, mental health consultants are clearly a resource that is in high demand, and there are not anywhere enough mental health consultants to be able to do the work. And so in Family Connections, we like to think about what are all of the many things that people can be doing even if they aren't mental health consultants. And so we like to support providers in terms of thinking about and developing their skills in self-reflection, their own self-care, and their skills in perspective taking. All three of these foster social and emotional well-being and resiliency. And when our staff are more resilient and regulated, they're able to have many of the competencies that all of you listed when you were thinking about mental health providers. So, in thinking about that in the next slide, we like to think that not everything that is faced can be changed, but certainly nothing can be changed until it is faced. And so part of our work is bringing into the room the voices, if we can move to the next slide, the questions, the wonderings of everyone that's involved. So I'm going to very, very, very quickly go through the consultative stance, and my apologies for moving so quickly, but the consultative stance is an approach to early childhood mental health consultation developed by Kadisha Johnson and Charles Brenneman. You can Google this and find many an article by them on the web. But the consultative stance is the way of being for the mental health consultant. It's a collaborative process. We come in avoiding the position of experts. We join with people. It's a parallel process, and that's one of our organizing principles. So the way, hopefully, that the mental health consultant is with other people will be the way that, might be with a director, is the way that the director will be with teachers, or teachers will be with parents, however we look at that. It's also a way of really understanding, and it was such a big word, another person's subjective experience. That perspective taking is so important. We've talked about relationship, and if we go to the next slide, we know that a big piece of relationship is trust, and that change doesn't happen until we have trust. Another component of the consultative stance is always, in the next slide, a wondering instead of knowing. We don't know what is happening for other people. We can assume, we can have hypotheses, but if we come from a stance of wondering, we're able to make those relationships. And the last few, moving quickly, would be that we really want to hear and represent all of the voices in the room, and those might be diverse voices with differing perspectives. We also really want to amplify the child's voice and use their behavior as our language. So we're also knowing that this is, in the next slide, not a rapid process. We can't come in, make a recommendation, and leave. We often plant a lot of seeds. We may do some weeding and some watering and some fertilizing, and hopefully we get to see the fruition, the child blossom or bloom, the teacher learn new skills or understand behavior in different way. But in the last slide, one of our most important roles is constantly holding the hope, that it is our job to be holding the hope when it feels like a situation may be hopeless, when nothing has helped, when nothing has worked. So what I'd like to do is to spend our last, we've got about 5 more minutes together. I'd like to spend 2 of those looking at a video. So I'd like you to watch this video. It's a day in the life of a mental health consultant. And I know Kathy mentioned the work from with the National Center on Excellence and our colleagues at the National Center on Early Childhood Health and Wellness. So they created a mental health consultation tool that's available on site, that's in our resources as well. They did come out and tape for a day, and so I had the honor of being taped. There's some things in this tape that I'm very excited about and proud about. There are other things that I wish I could edit or delete, but since this is used for learning, I'll ask you to watch it and see if you see things that we've talked about today, what perhaps appeared effective, what might have been more effective.
In this video, you will see examples of how the mental health consultant works systemically with program leaders, staff, families, and children.
So you know what we're going to do today? We're going to read. Do people remember this book?
Yeah! Read it!
Infant and early childhood mental health consultants work with program leaders, staff, and families to support young children's social emotional development.
I try to use humor and have fun, and also I think do a lot of rapport building even before talking about mental health. So there's a lot of sharing that goes on with families. Of course. Well, you're a mama.
Yeah, I still,
yeah, you're both mamas, and mamas worry.
always.
Yeah.
No 2 days look the same.
Yeah, I noticed that.
Teachers spend more time together often than husband and wives in terms of awake time in very challenging situations. And they really need to learn each other's rhythm and how they can become seamless in their work.
Well, I think that's one of the things that that we've talked about, that I appreciate so much about the two of you as a teaching team, is that you each bring such different skills and strengths to the classroom that you really, I think, complement each other.
So often it's from a stance of wondering with 2 people together. I wonder what that was like for you. Or I noticed that this was happening. Can you share a little bit about what that was like for you? And then thinking about how we might work together to honor and respect each other's perspectives, continue to support the kids in the class.
Thanks. So if you want to move on to the next slide, and I think if people have thoughts or comments that you'd be willing to write in the chat, that would be wonderful. And we also have a brief evaluation. Debbie, will you take that over for us now?
Yes. Hello, everyone. Please give us your thoughts and ideas in the chat box about the content of the session and what you might like to hear more about, or how you felt about the session today. But I'd like to take just a moment to sincerely thank our presenters and facilitators today for this interesting and provocative and informative opportunity. We appreciated all the comments in the chat box from folks, and just like to thank you folks for putting this session together for us. So keep working on the evaluation, and we'll talk to you next time. Thank you.